friends and colleagues. Today we will continue our lectures about hyponatremia and we will talk about treatment of hyponatremia. This is our agenda. During treatment of hyponatremia, we depend on the symptoms and duration of hyponatremia. We classify patients to acute and chronic. Acute hyponatremia when the symptoms develop within 48 hours, and chronic patients with chronic hyponatremia if it lasts for more than 48 hours. And also we depend on the symptoms, if the patients are symptomatic or they are asymptomatic. So we depend on acute and chronic, symptomatic or asymptomatic. Patients with acute hyponatremia at higher risk, if not treated, at higher risk of cerebral edema, and patients with chronic hyponatremia at higher risk of osmotic demyelination if the correction of sodium is too rapid or too aggressive, and if it usually occurs when the correction of sodium is more than 12 millimole per day. There are general rules during treatment of hyponatremia we shouldn't forget. General rule number 1 is that the correction of sodium, the correction rate is of 1 to 1.5 millimole per liter in any given hour. We shouldn't exceed that rate. We shouldn't increase the sodium by more than 1 to 1.5 millimole per liter per hour. This is the hour correction. And we shouldn't, what is the goal of our treatment? The goal of our treatment is to increase the sodium by 6 to 10 millimole per liter per day. Our goal is to increase the sodium by 6 to 10 millimole per day, and we shouldn't increase, but don't forget that number, we shouldn't increase the sodium by more than 12 millimole per day. Don't forget that number. We shouldn't increase sodium more than 12 millimole per day or 18 millimole in 48 hours. So at any given hour, the correction rate shouldn't exceed 1 to 1.5 millimole per liter per hour, and the goal of treatment is 6 to 10 millimole per day, and we shouldn't increase sodium by more than 12 millimole per day or 18 millimole per 48 hours. This slide and this information, these rules are very important. Now we'll talk about treatment of acute symptomatic hyponatremia. Patients with acute symptomatic hyponatremia are at increased risk of neurological complications, and they need immediate treatment with hypertonic saline or 3% sodium chloride. We started treatment by acute because it is acute and symptoms are present. We usually start by IV bolus. We give IV bolus of hypertonic saline or 3% sodium chloride, aiming to increase the sodium by 4 to 6 millimole per liter, usually in a period of 4 to 6 hours. So we give IV bolus of hypertonic saline, aiming to increase the sodium by 4 to 6 millimole per hour to reverse the cerebral edema. And usually we give that bolus at 1 to 2 milli per kg of hypertonic saline, usually over 30 minutes, over 30 to 60 minutes, but usually we give it over 30 minutes. And usually the most common amount of fluid given is 150 milli of hypertonic saline. So again, in patient with acute and symptomatic hyponatremia, we start by IV bolus of hypertonic saline around 150 milli over 30 minutes, or hypertonic saline at a rate of 1 to 2 milli per kg over 60 minutes. We can give loop diuretic, a low dose of loop diuretic to enhance the water excretion. While we are giving or after giving an IV bolus, patients should be monitored. This is very important. Monitored for what? For changes, to search for neurological manifestations, if it is improved or worsened or not. Lung status, if there is overload or more crepitations on the chest or not. And of course, we should check for the serum electrolyte, especially sodium, every 2 hours. So very close monitoring of our patients for the electrolytes, neurological manifestations, and pulmonary status every 2 hours. And this IV bolus, as we said, usually in an amount of 1 to 2 millimole per kg or 150 milli of hypertonic saline can be repeated after 2 to 3 hours if the response is not adequate. How we know that the response is not adequate? If the neurological manifestations didn't improve, and usually it takes some time, or the sodium didn't increase by 4 to 6 millimole per liter. We can give another bolus of hypertonic saline. If there is improvement with IV boluses, with the IV bolus, if there is improvement in the neurological manifestations and in the serum sodium, and its sodium increased by 4 to 6 millimole per minute, we should continue by IV infusion. After the IV bolus, we should continue sodium correction by IV infusion. How to calculate the amount of hypertonic saline to be given as an IV infusion? We use this formula, what is called Adrog and Madeus formula. It is the most common formula. This is the equation, or this is the formula. For each 1 liter, of the given fluid, we calculate the change in sodium. Of course, if we give hypertonic saline, which is the most common, hypertonic saline, or the 3% sodium chloride, the sodium content is 513 millimole per liter. So this equation will calculate the change in sodium that will occur in the patient with giving 1 liter of hypertonic saline. This equation is the infused sodium in the given fluid minus the measured sodium of the patients over total body water plus 1. So the infused sodium, and usually we give hypertonic saline, it is 513 minus the measured sodium of the patient over total body water plus 1. How we calculate the total body water? From here, total body water is different in males from females. In patients less than 65 years of age, it is usually total body water represents around 60% of male patients' body weight, and in female it represents 50% of the body weight. In patients over 65 years of age, in males it is 50% of the body weight, while in females it is 0.45, it is around 45% of the body weight. This slide is very important. How to calculate and what is the dose of IV infusion? After we give the IV bolus, we give IV infusion. And don't forget the general rules. We should we shouldn't increase the sodium by more than 12 per day, 12 millimole per day, and our goal is around 6 or 8 to 10 millimole per day. Another method to calculate the IV infusion or how to give the IV infusion of hypertonic saline is by calculating the sodium deficit. Sodium deficit will equal from this equation, it equals total body water times desired sodium minus the actual sodium. Now let's analyze this. Total body water, as we give in the previous slide, it is around 60% of body weight in males and 50% body weight in females. And if the patient is more than 65 years, it is around 50% of body weight in males and 45% body weight in females. This is how we calculate the total body water. Here, this is the desired sodium. The desired sodium will be calculated from the actual sodium. So if the actual sodium of the patient is 115, so the desired sodium should be more than 10. And as we said in the general rule, we should increase the sodium. Our goal to increase the sodium in one day by around 10 millimole. So the desired sodium here is 10 millimole over the actual. It is the actual or the measured of the patient is 115, so the desired is 125. So to calculate in this patient, the desired sodium is 125. Here 125 minus the actual sodium is 115, so this will give 10 times total body water. Total body water in this patient, who is 53 years old, male, 70 kilograms, so it is 60% of his body weight, so it is 0.6 times his body weight, 70 kilos, times 10, which is the desired minus actual sodium. So sodium deficit is around 420 millimole of sodium. Sodium deficit is 420. As we said before, in hypertonic saline, 3% hypertonic saline, which is the most commonly used, the sodium content is 513 millimole for each 1 liter of hypertonic saline. So if we give the patient 1 liter of hypertonic saline, it will increase sodium by 513, which is more than the sodium deficit in this patient. This is another method how to compensate or how to treat sodium or hyponatremia. But the most common one is the previous one, is the Madius equation, which is the change in sodium equals the infused sodium minus the measures over total body weight plus 1. What about chronic symptomatic hyponatremia? Chronic and symptomatic hyponatremia, these patients are chronic patients. Usually they are like patients of heart failure, liver cirrhosis. They are chronic patients having symptomatic hyponatremia. So in this patient, because they have symptoms, we should correct immediately by giving hypertonic saline. And hypertonic saline will be given for this patient, as we said before, by the IV infusion. Remember the general rule, your goal is 8 to 10 millimole per day. Don't increase over 12 millimole to avoid cerebral montine demyelination. And in these patients, the pathogenesis is that there is more water in their bodies. There is increased water diluting the sodium. So we can give furosemide to this patient to increase the water loss. The main problem here is the increased water in their bodies. So we should get rid of this water, and we can ask this patient, of course, to to do water restriction, to increase the water intake, to decrease the water intake and increase the water loss. These are the methods. And of course, we should monitor serum sodium. These are the general rules. What about chronic asymptomatic hyponatremia? Are patients with chronic asymptomatic hyponatremia are not at risk? No. Patients with chronic asymptomatic hyponatremia at higher mortality rates, and usually they have gait disturbance, which make them at higher risk for falls and fractures. So from these data, patients with asymptomatic hyponatremia should be treated, and they should be evaluated to exclude hypothyroidism, adrenal insufficiency, and syndrome of inappropriate antidiuretic hormone, and their medications should be revised. What are our options to treat chronic asymptomatic hyponatremia? The most important and the first line method is fluid restriction. As we said before, the main pathogenesis here is increased total body water, diluting serum sodium. So the main problem is the increased water in their bodies, and what we should do is either decrease the intake by fluid restriction, which is the first line treatment, or increasing water loss. So the first line is fluid restriction. Second line, we can cause inhibition of vasopressin. Again, what is vasopressin? Vasopressin is the antidiuretic hormone. From its name, it is antidiuretic. It will decrease the diuresis, causing more water in our body. We don't need this, so we give drugs that will inhibit this antidiuretic hormone, which is the vasopressin. What are the options or the drugs causing inhibition of this antidiuretic hormone or the vasopressin action? Lithium, but usually it is not used nowadays in this type of indications. The second agent is dimeclocycline. Dimeclocycline in a dose of 300 to 600 milligram twice daily. It is effective. Dimeclocycline is effective, but it has some side effects. Also, the vasopressin antagonists or vaptans can be used, especially in eovolemic or hypervolemic patients, but they are expensive. The third option is increase the water loss. How we increase the water loss? By increasing salt intake. If we increase the salt intake and we give patient furosemide with increasing salt intake, it will increase the free water loss. So giving furosemide with increasing salt intake is effective, causing more water loss. And we can use urea. Urea will cause osmotic diuresis and increased water loss in a dose of 30 to 60 grams per day. And with this water loss, it will correct hyponatremia, but urea, usually giving urea to patient is unpalatable, and they will complain of GIT symptoms. To summarize, don't forget the general rules that at any given hour the correction rate shouldn't exceed 1.5 millimole per liter, and the goal is 6 to 10 millimole per day, and don't increase serum sodium by more than 12 millimole per day. If your patient has symptoms, if it is within 48 hours, so it is acute and symptomatic hyponatremia, you should give the patient start by IV bolus of hypertonic saline, at a dose of 1 to 2 milli per kg, or 150 milli of hypertonic saline over 30 minutes, and monitor your patient and recheck sodium and neurological manifestations and pulmonary status after every 2 hours. If the symptoms persist, you can repeat this bolus after 2 to 3 hours. And if the sodium increase in these 3 to 4 hours by around 4 to 6 millimole, you can shift to IV infusion. IV infusion by Mendes equation, the change in the serum sodium equals infused sodium, and usually it is in hypertonic saline it's 513 minus the measured sodium over total body water plus 1. This equation will give you the change that will occur in the sodium for each 1 liter of hypertonic saline or the given fluid. You can give furosemide to increase the water loss. If these symptoms occur in chronic patients, you should give hypertonic saline by IV infusion, or you can give 1 shot of IV bolus hypertonic saline and then continue by IV infusion as we described before. You can give furosemide to increase the water loss, and as we said before, you should ask your patient to do water restriction. In asymptomatic patient, as we said, the first line is water restriction, and of course treatment of the cause if it is identified, but the most important is water restriction. You can inhibit antidiuretic hormone by demeclocycline or vaptans, and you can increase water loss or solute by increasing solute intake by giving urea, or increase salt intake causing more free water loss, correcting serum sodium. Thank you.